questions to this point about the genes? Are you guys gonna memorize the genetics section on this in the book?
No.
No. Yay. Okay, good. Yeah, there's things about this book. If I get asked to teach this again, I will make major modifications. Bless you. As I'm going through, and I understand. I mean, there's a lot of great information in this book. I don't want to put anybody down, but I think there are areas where they tried to simplify it to make it more digestible, but they simplified it to the point of being incorrect molecularly. So that's not a good thing. All right, so diagnosis for familial TAD. First off is a chest x-ray. So, you know, a lot of times for especially older patients, this is how it's wind up being caught, even just aneurysms in general. The patient goes in for something else, gets a chest x-ray, and they either see like the aortic knob on there, so like a bulging or dilatation around the aortic root. Just it looks like a knob hanging off there. Something like that. Sometimes if people just have a slight chest pressure or pain with no other cardiac symptoms, primary care might send you for a chest x-ray, making sure it's not pulmonary, and then they find this, that type of thing. But of course, any type of major chest pain, you're not going to play around with that. You're sending them straight to the ER if you're in a clinic, right? So the other way is through echo. We've seen some of those echo pictures that were pretty cool. Anybody ever heard of a transesophageal echo?
Yes. Yes.
Awesome. So those are really neat. Patients don't care for them very much because you've got to swallow the big echo probe. But the great thing about a TEE is, of course, you're looking back, you're behind the heart, so you have a much better view of the aortic valve from that area. We use TEE when we're doing well, in heart surgery, we look at it, but especially when we're doing our transcatheter aortic valves, we like to get TEE before surgery because it just gives us a much better view in sizing of the annulus for that valve. CT scan, we saw some of those nice CT pictures. What would be a good benefit of CT over MRI if you have somebody in the ER with chest pain and suspected dissection?
Speed.
Speed, yep. It's faster, and patients, you know, they can lie still for a few minutes versus 30 minutes with the MRI. So really you're looking for presence of that root dilatation or dissection, some type of aneurysm in the area. It's a weakening in the wall, right? Absence of other genetic cause. So not Marfan's, not Ehlers-Danlos, not any of those other things that can happen to cause connective tissue weakening. And also positive family history. So again, autosomal dominant, most likely one of your parents has this manifested. Treatment. If you rupture, don't pass go, you're going to surgery, right? You know, typically CT's been gotten by the ER doc. Somebody has seen them. They're on the way to the CT surgeon upstairs, moving quickly, unless it's at the point where the CT surgeon thinks that there's no chance, and then they'll just put them in the ICU for the family to basically be able to say their goodbyes. But in general, this is, you're moving immediately to surgery if there's a rupture. If you have the finding of an aneurysm, well, it's size dependent, right? 1-2 centimeter thoracic aneurysm, Probably not going to put the patient yet through any type of surgery for that. Usually once that aneurysm hits about 5 centimeters, that's where they really start looking to treat these aneurysms. If you have Marfan, it's probably going to be earlier. Couple of different ways to treat thoracic aneurysms. So you can either do open surgery and grafting. So that's where you open this patient completely. You're clamping on either ends of the aneurysm, right? Proximally, distally. You're going to take that out and you're going to sew in a graft. It takes a few hours. It's not, doctors who are good at it, our doctors are good at it. Dr. Buss is specifically very, very good at dissections here in town. But it still takes a long time to do these. These guys have to be really meticulous, especially if that aneurysm is at the aortic root. Then we're talking about potentially root repair, root replacement, and a valve replacement on top of that. That's a long surgery. Is everybody with me? I feel like I'm losing people. Okay, thank you. Okay, so this isn't simple. So surgeons want patients to wait as long as they can because this is not easy to recover from. We're talking at least a week in the hospital after a surgery like that. And we're talking a month to 6 weeks recovery easily because we're talking full sternotomy here. Full zipper to do something like this. Maybe even more if you're on your side to replace whatever. Then there's also endovascular repair, such as T-bar. So thoracic endovascular aortic replacement. I'm going to show you guys some stuff about that in a minute. If you're just watching these patients, so they have a small aneurysm, you're watching them, again, you're going to put them on beta blockers, just like Marfan, and they're going to have very similar lifestyle, education limitations like Marfan's. So, no contact sports, no rough sports, no, these people aren't doing Ironmans. You're not going to put them through anything like that or let them. No smoking, decongestants, yes.
How early is this manifesting?
Variable expressivity. Yep, so some patients can manifest pretty young, like childhood, with the beginning of aneurysms, and then others make it quite a long time. It's all over the place. But the other thing you have to remember is, if you're at risk for an aneurysm in the thoracic aorta, you're going to be at risk for cerebral aneurysms, everything else too, right? And we have seen that when I used to work for the endovascular neurosurgeons. We would see that every now and then. Okay, so I'm going to show you guys a treatment video, surgical video. I think it's pretty darn cool how they do this. So the thoracic, or the endovascular way they do this. I stole this from a surgeon's office. So I'm going to pass this around. Don't crush it because he has no idea that I took this from him. But he's in surgery right now, so he doesn't need to show patients. So this is an actual thoracic endograft that would be used in the thoracic aorta. Okay, so you can see it gets squished down, and they can crimp it down inside of the thing, and when it's released, it gets nice and big. And this is a.
You know how long something like that would be allowed to stay in the body?
Forever.
Forever.
Yep. I'm assuming it's made of Dacron inside there. So, and this is a model of what it looks like inside the arch here. So this would be, obviously, the bulge of the aneurysm, right? And this goes in and covers all the way around. So obviously this is arch. It's like a type 1 arch, right? Question for you. If you're doing this endovascularly, what do you have to be careful of? Because this is covered, right?
You don't put it too far up and block the something.
You got it. Last thing you want to do is come up and, oopsies, block everything off. That would be that would be very, very unfortunate in your license. So anyway, here I'll pass this one this way and this one this way, so you can feel squish squeeze all of that stuff. So there's a couple different companies that make this. This video is actually from Gore. This is not a promotion for Gore in any way, shape, or form. I don't think I even know anyone who works for Gore, but I thought it was the best video. I found a video of a European surgeon actually doing one, but it was like 5 seconds of him in the OR for every 20 seconds of him standing like this, acting really kind of weird and European cool, talking to the camera. So I chose this video instead.
And it could be dead.
I know.
Alright, just look cool.
Oh man, come on. Okay, wait, I gotta pull this over, right? I'm gonna have this thing down pat by the time we are done with this class.
Then they'll change it by now.
Exactly.
You're an active senior citizen. You may work, travel, exercise. But while you're doing all of these things, you may not realize that you can have a silent killer inside your body. It's called TAA, thoracic aortic aneurysm.
The aorta is a major artery of the body that delivers blood from the heart to the arteries. What a thoracic aneurysm is a ballooning of that artery within the chest as a result of a weakening in the wall of that artery. In time, that weakening results in progressive growth of this ballooned area, and if untreated, can rupture, resulting in internal bleeding and death.
TAAs kill over 6,000 people in the U.S. each year, making this disease a leading cause of death among seniors. Unfortunately, many people who suffer from this condition don't realize it until it's too late. Over 75% of patients with ruptured thoracic aortas die within 24 hours after symptoms are first felt.
A thoracic aortic aneurysm, in general, doesn't cause any symptoms. However, in some occasions, the expansion of the aorta, of the aneurysm, causes some chest discomfort by the pressure in the surrounding structures, or a reflex mechanism may lead to cough.
People who are over 60 years of age and have one or more of the following conditions may be at risk of having a TAA: high blood pressure, current or former smoker, arteriosclerosis, or family history of aneurysms. Regular screenings for people who are at high risk of having a TAA can be critical to identifying and treating the condition early.
Chest X-ray is the first test to do. If there is a suspicion, you may do ultrasound or echocardiogram of the cardiac structures and of the aorta above the heart. If the suspicion is still there, or even further, then you can go to more sophisticated technology, like MRI, CT scanning of the aorta, etc. But I would like to emphasize that chest X-ray is probably the best way to start.
If diagnosed with a TAA, treatment could begin with medical management, which usually includes keeping your blood pressure under control, quitting smoking, reducing dietary cholesterol, and monitoring the aneurysm for growth. Until recently, if surgical intervention was necessary, the only option was open surgical repair, which requires opening the chest wall and replacing the diseased aorta with a synthetic graft.
The open procedure of a thoracic aortic aneurysm involves opening the chest and replacing that ballooned or aneurysmal portion of the aorta with a synthetic substitute. That generally is a several-hour procedure with approximately 1 week hospital stay.
However, with approval in the U.S. of the Gore-Tag thoracic endoprosthesis, physicians and their patients have a less invasive alternative to traditional open chest surgery that can improve outcomes and minimize hospitalization.
As it is a minimally invasive approach to the treatment of this aneurysm, we anticipate that this can be performed often with a local or regional anesthesia. There's a quicker recovery and return to normal activities with generally an overnight hospital stay.
When compared to open surgical therapy, endovascular repair with the GORTAC device results in a shorter hospital stay, faster return to normal activity, and a significantly lower incidence of complications or problems occurring during and after the procedure. The device is backed by encouraging clinical data showing that the risk of mortality or death related to the procedure or the aneurysm is significantly lower when patients are treated with the GORTAC device. One of Dr. Carraccio's recent patients was diagnosed with a thoracic aortic aneurysm after doctors noticed a suspicious finding on a routine chest x-ray for another condition. After consulting with Dr. Carraccio at Mount Sinai Medical Center in New York, the patient decided to undergo endovascular repair of his TAA using the GORTAC device.
Today's case is a good example of a patient that will benefit from an endovascular thoracic repair. Essentially, we will approach this patient with local anesthesia and pass the endoprosthesis through his abdominal and thoracic aorta, essentially excluding the aneurysmal portion of his aorta as demonstrated here. We anticipate an overnight recovery within the hospital and discharge on the following day.
The GORTAC thoracic endoprosthesis is an implantable device that is inserted through a small incision in the patient's groin and advanced to the diseased area of the aorta. Once the tube-shaped device is correctly positioned across the aneurysm, it is deployed to reline the aorta, seal off the aneurysm, and make a new path for blood flow. By doing this, the device is designed to reduce the pressure within the aneurysm sac and prevent the aneurysm from rupturing.
Procedure went quite well. He basically had this performed under local anesthesia with some sedation. We accessed the left groin and used the endovascular device to bridge the aneurysm. And as you can see on the angiograms, it was fully excluded. We anticipate him doing well with an overnight stay and hopefully be home tomorrow afternoon. Ms. Berman, how are you feeling? Very good. Okay, the procedure went as planned, very smoothly. Everything is fixed in terms of the aneurysm. We're going to keep you here in the length still for a little while so that the area can heal. And we're going to watch you overnight and see about getting you home tomorrow. In the meanwhile, do you have any pain in the legs or numbness in the legs that you can feel? Or your legs feel okay? Okay. Very good. You're breathing well, no chest pain, no difficulty breathing at all? Okay. Very good. Excellent. Very good, sir.
The availability of the GORTAC device ushers in a new era of less invasive repair of thoracic aortic aneurysms. As with any surgical or medical procedure, there are potential complications with both the open surgical and endovascular treatment of a TAA. Patients requiring intervention should discuss the risks and benefits with their doctor and decide which option is best for them.
Okay. So a couple of cool things about that is, I mean, obviously, 1 night, 2 nights stay in the hospital is a whole lot better than full sternotomy, week in the hospital, all the rehab, everything after that, right? Potential complications. Like a cath, if you're sticking wires up someone at any point, you have the risk of rupture, especially because you're sticking a wire up into a known aneurysm, which is already at a risk for rupture, right? So at Health Park, when we do these, a few years ago, until we had a hybrid OR, they would do these in our endovascular lab, which is it's situated next to ORs. It's where we do all of our cerebral angios and everything. So what they would do is there's a vascular surgeon in town who likes to do these, and one of our CT surgeons likes to do them. And so they do them together. So they're in there together because the vascular guy has a lot of the real wire skills and all that kind of stuff. The CT guy does too. But also, if something were to happen, then the CT guy's there. They can be on, bypass within under a minute, crack the chest, and be on their way. So it's still, you know, it is a risky procedure, but given the alternative, I think I'd probably try it if possible as well. So this is I thought, a pretty cool picture of what an open surgical treatment graft would look like. So you can see this is the end result. So they would have clamped on either side, cut it out, sewn the graft in on both sides, and off you go. So again, this is just for descending, right? Because you can't, like we just said, you can't put that in ascending. That would cause problems. However, for ascending or like an aortic root aneurysm, you would sew in a graft down here, right? And then you may either need a root repair or and or a valve. So the top one, they've left the valve in place. You can see the native valve in the top. The smaller picture, they put a mechanical valve in there, but obviously it would depend on what all they have to do. I saw a patient about 2 months ago who had a dissection about 10, 15 years ago, I think, in Naples, and great CT surgeon down there, really good guys, good friends with our guys. He had to, he repaired all of that himself without a graft. He was able to repair it naturally. Then he had to sew in what's called a freestyle aortic valve, which is basically a stentless valve. So basically he sewed the flaps on, and then he had to reattach the coronaries. And the only area that he had to reattach the coronary was basically right at the aortic annulus. What was left, that he had sewn the flaps onto the aortic annulus. So it was really cool. I mean, the surgeon saved this guy's life because this was all he had to work with to do. The problem for us was the guy now needed a new aortic valve because that one had failed, having been about 15 years out now, right? He really wasn't another good surgical candidate after all of that, so we wanted to put one of our transcatheter valves in there, but we couldn't because the only place he had to sew the coronary back on was so low, we would have occluded it with any of the valves that we have to put in. So poor guy wound up, the surgeon in Naples wound up reopening the guy. The guy took on the risk, said he would do it. He reopened him. He actually did pretty well. He called me Monday. He said, I found this number in my phone. I'm like, yeah, don't you remember? He goes, oh, that's who you are. He's like, I'm keeping your number anyway. You were so nice. Okay. So, but that was a cool thing. But what, I mean, you know, these guys are real artists and carpenters and mix of, I mean, these vascular guys do really kind of cool, crazy stuff. What do you guys think about that stuff going around? It's pretty neat, huh? Yeah. All right, and these are some of the resources where I got stuff from for familial TAD. Any questions on thoracic aneurysms, that kind of stuff? Bless you. No? Okay, so I think we only have like 3 lectures left, if I'm not mistaken. I mean, we're almost done. So I may not get through all the chapters in the book. I may pick and choose things that I find interesting, or you know. But let's face it, it's really about me. So there may be stuff that I touch on, hit on, gloss on, and then spend more time on other stuff that I want to talk about, because I'm the one who's saying all this together. But that doesn't get you out of reading your text, unfortunately. So keep reading. Keep reading your text, because there may be stuff that's in the text that winds up on your final that I gloss over. If there's something specific, like I just told you, don't read the genetics portion of this because it's wrong, I will tell you, don't read that. But at the moment, the rest of the stuff that we haven't covered yet, I'm just giving you a heads up to go ahead and read. And as I come across stuff that I tell you to ignore, I will let you know. Does that sound fair enough? Okay. All right. If there's anything that we haven't covered that's not really in the text that y'all think might be interesting for us to talk about or to cover in the next 3 lectures, shoot me an email and let's find something fun and cool to look at, because some of the stuff is not. And like for me, I'd rather spend a good full 2 hours on gene therapy and some of the ethics and stuff that goes along with this than hypercholesterol. Yeah, too much cholesterol. I mean, let's face it. Let's all go eat rabbit food and be miserable. But I'd rather talk about other stuff. So, but if there are disease states or anything that you guys find interesting that's not in there that you want me to think about or touch on, shoot me an email and even if it's not going to be on the test, I'd rather us have fun the last 3 lectures than be bogged down in really, really bad, boring stuff. All right. Anybody, any more tests this week? You guys good?
Oh, yeah.
Grumble, grumble, grumble. Mr. Smith is right. All right, guys. Well, good luck.
Thank you.
See you Friday.
Okay.
Sorry.